All right, opioid medications. So I did this last year. As many of you probably listening to the news and probably talked about in class and at different sessions and talks throughout your careers as M1s and M2s, you've probably heard about the opioid crisis. So when I was in pharmacy school, this was something I had read, and the professor, who was a pain management professor, she had shown me, and I actually worked with her quite a bit, that this, even though it's getting national attention within the past few years, the national opioid epidemic, it's been going on for quite a while. This paper in the New England Journal from November 18th, 2010, this is so, you know things wax and wane in popularity and sort of reach national attention, but it's been going on for quite a bit of time, and many people have died and have suffered from and battled addiction. So some of the things I've included in the review at the very end, I've included equal analgesic dosing tables. Equal analgesic dosing tables are, morphine, fentanyl, pyridine, oxycodone, codeine, all the different drugs that we're going to talk about. How do we switch between them if we're trying to, control a patient's pain? So we use this table, and this gives us an idea as to how to change between the different medications and safely provide our patients some, pain control. Not something you're going to need to use now. In addition, I also have a couple of urine drug screening testing tables. Some of the opioid metabolites you can see when you're testing someone's urine. Some of the benzodiazepine metabolites that can occur. And then finally, some false positives. There are quite a few drugs that can cause false positive in urine drug screens. So just a bunch of information as you go forward on your lectures if you ever, or your rotations if you're ever interested. All right. So just a general sort of summary of opioids mechanisms. As you should be well aware of now, opioids activate the mu receptor. They are mu receptor agonists, and this mu receptor agonist is responsible for analgesia, euphoria, and respiratory depression. Uses include acute pain, chronic pain, and cancer pain. The other sort of kind of pain, I guess you could throw labor pain, any kind of somatic pain. All have a high potential for abuse, so don't ever let anyone tell you that tramadol is a weaker mu agonist, therefore there's less potential of abuse. They are wrong. They all need to be, you need to treat every opioid medication with a certain level of respect for the fact that there's a possibility for abuse. The opioid toxicity triad that you need to burn into your brain, not your membrane, your brain, is meiosis or pinpoint pupils, sedation, and respiratory depression. If you have a patient who is presenting with pinpoint pupils, they're tired, and they are breathing less, I can guarantee you that's opioid. That's a triad that you only see with the opioid overdose. There are lots of drug interactions, and they're not the kinetic interactions that we've talked about before. They are more dynamic interactions. These are, respiratory depressive agents. They're sedative agents. So if you're taking another CNS depressant, alcohol, benzos, etc., there could be an issue with respiratory depression or sedation. Reversal agents, another thing you need to burn into your membrane. Naloxone or Narcan is it's our mu antagonist. So this is what we're using acutely when unfortunately you find a patient slumped over on the street who was overdosing from heroin. You give them Narcan to bring them back. Naltrexone is another mu antagonist. It's long-acting, and it's actually used long-term for abstinence. So you could give a patient a shot of naltrexone. It's IM, lasts for about a month, and if they attempt to use an opioid medication, it won't work because they're already being blocked by the naltrexone. Interestingly enough, these monthly intramuscular injections, for whatever reason, seem to have some effect in alcohol abuse and weight loss as well. So central side effects of the mu opioids. So you have to remember that the mu opioid receptors are everywhere in the body. Now, obviously, the ones that were activating for pain control, I believe it's in the periductal gray matter. I don't know how I just remembered that. In the central nervous system in the brain. So opioids to actually have pain relief need to get into the central nervous system. And so we can see effects such as euphoria, sedation, respiratory depression, meiosis, pinpoint pupils, nausea, vomiting, and cough suppression. We'll get back to cough suppression in the future. In peripheral side effects, so these medications, because the mu receptors are in the periphery, also have effect. The biggest things you want to remember: constipation, because we'll talk about a medication that is used for diarrhea because it's such a constipating. Flushing and itching. You'll see that a lot of patients have in their medical records that they're allergic to codeine and there was a rash, or they're allergic to morphine and they got a rash, and you dig into it and they were like, I got really itchy. It wasn't hives and my throat didn't swell. They're suffering from a side effect of the drug. Just a key point about the constipation side effect. You'll hear some attendings say eventually you'll become tolerant to the effects of opioids causing you to be constipated. This is incorrect. All patients who are on high dose or chronic doses of opioid medications need to be on stool softeners and laxatives to ensure that they don't become constipated. They will never become tolerant of the constipating effects of opioids. So very, very important sort of summary slide for all things opioids. All right, so the way it's broken down in your lecture, I'm just going to follow that, even though it's not, I probably would have done it a different way. I just wanted to stick with the way it was in class. So strong agonist is sort of a relative term. I think a better term would be higher efficacy or more potent agonists. Because I believe what they're trying to get at here is lower dose having more effect, not that, it's got a strong effect, because all of these opioids, when dosed relatively high, can have a pretty high effect. But what I think the point they're getting at here is potent agent. So we'll start off with morphine. Just in general, acute pain, cancer pain. It's also used in epidural anesthesia, and it's also used for MIs or heart attacks, which is something that's sort of forgotten, and that's why it's bolded. Morphine is metabolized through glucuronidation, and so that sort of bypasses some of the liver enzymes, and so we don't really worry about interactions in that sense with morphine. There are lots of there's a big first pass metabolism. It is heavily broken down in the liver. I know I said that it doesn't have the liver interactions of the CYP system, but it's still metabolized in the liver, and so you will end up giving higher doses of morphine. Morphine tends to be one of the less potent opioids that require higher doses to get certain levels of pain relief. In addition, when it's metabolized, it can be metabolized into morphine 6-glucuronide, and that metabolite is actually twice as potent as morphine itself. And as we talked about before, all of the side effects, the mechanism of action, interactions from that first summary slide all apply to morphine. So you really, now that you know how an opioid works, if you just remember morphine is one of them, it can also be used for heart attacks. You sort of have it all wrapped up. Fentanyl. Fentanyl is probably the most potent out of all of the four that are on this slide, where the rest are dosed in milligrams. Fentanyl is dosed in micrograms. So it can be used in patch form for chronic pain and cancer pain. And it's also used for general anesthesia and pain in general anesthesia. So its forms, it is an IV and transdermal patch. As I said before, it's probably one of the most potent out of this four. It's dosed in micrograms. And it is a 3A4-CYP substrate. So therefore, if you have inhibitors of the 3A4 system, some statins, you could see some drug interaction with fentanyl. And as I've talked about before, and I'll repeat again, that first summary slide of opioids, everything applies, side effects, mechanism, so forth. Methadone. Methadone is a little special because not only is it a mu agonist, but it's also an NMDA antagonist. So it has a little bit of benefit in that even though it's an opioid, it can cause some pain relief through another mechanism, and so we don't rely as heavily on the mu agonism, and so therefore we don't get we can sort of avoid some of the side effects of having to dose it higher and have to deal with those. Methadone is used for two things. It is used for severe pain and opioid dependence. So methadone is one of the medications that you have to go specifically to a clinic. And if you do go to a clinic, so methadone is one of the medications that it can be dispensed at a pharmacy. Don't let anybody fool you on that. It can only be dispensed in a pharmacy for severe pain. So on the prescription, it has to say for pain. Now, when it's dispensed for opioid dependence, it can only be dispensed in a methadone clinic. Its kinetics, it's got a little bit of funky kinetics, and that's what makes it difficult dealing with methadone. It's very highly plasma protein bound. It also has a very long half-life, 25 to 52 hours. And so, most drugs that you've heard about so far have a half-life that's significantly less than 24 hours. So for that fact, sometimes, it builds up and it stacks. So if you dose it a certain amount every day, it eventually can lead up. So therefore, sometimes for this drug, we'll do QOD, which is every other day dosing. And so we can get toxicities from accumulating. And then finally, one of the bad side effects that you don't see with some of the other opioids is QT prolongation. I know I've said that before. Methadone is another one of those drugs that you need to put on your list of drugs that can prolong the QT and lead to torsades. And so it's got prolonged QT. It's got QT prolonging potential. It builds up as a toxic. It builds up in your body because of its long half-life, and problems ensue. Because it has such a long half-life, it has minimal euphoria, and so therefore, it sort of falls into that range of being able to treat opioid dependence because of its minimal euphoria. We're not taking this drug and getting high from it. We're taking this drug and we're sort of keeping ourselves at baseline. I believe somewhere they put it prevents withdrawal. It doesn't. People can use it to stave off withdrawal. People will sometimes go to methadone clinics or try to get methadone because if they're using heroin or if they're using Oxycontin, they can actually take methadone to just sort of keep them at a baseline. Finally, we have meperidine. So meperidine is a very old drug. It's called Demerol. It's a synthetic agent. It's for acute pain. In some cases, people feel that, I don't want to give you oxy, I don't want to give you Vicodin or hydrocodone, I'll just give you a little meperidine shot. And that's what used to be done. Unfortunately, it has a toxic metabolite that builds up if you have renal insufficiency, and it can cause seizures and tremors. So it's not really used as much anymore. You may see it sometimes in some emergency rooms or acute care clinics. Moderate antagonists, as I said before, I don't really like that as much. I'd want you to think of it more as, moderate potency. But anyways, regardless, codeine. So I didn't include it in this lecture because I know you guys are strapped for time and it's already like 100 slides as it is and you guys don't have time for it. But I'll give you the little story. It's you guys don't have to take medicinal chemistry. I did, and so pretty much we learn how to draw the structure, like organic chemistry draw the structure of every drug. And it's very cool because our guy, our PhD showed us two tables or two pictures, and it was pretty much this thing that you have codeine and then you have hydrocodone, where one of the structures was changed from a hydroxyl group to like just a hydrogen. And then there was oxycodone, or oxycodone, which was just that hydroxy group turned into a ketone group. Same thing happened for morphine. There was a hydromorphone, which was a hydrogen, and there was oxymorphone. And I don't know if we have those. I don't think we have those on the list. But it's cool, like drug names, and with opioids, it's all relative to structure, and it's very interesting. But you guys don't have time for that. I apologize for digressing. Anyways, so codeine is a mild to moderate potency opioid, but what you're going to get, not tricked, but you'll sound really smart as if you know it's very good antitussive. And so when you take it as a cough suppressant, which is what antitussive means, when you get guaifenesin and codeine, Robitussin with codeine, like that, it's not for pain relief. It's because codeine, for whatever reason, is actually really good cough suppressant. So this is an extremely high yield pharmacology, pharmacokinetic concept that you will see this. So codeine, and I think I might have already mentioned this in the early kinetics lecture. So codeine is metabolized by 2D6 into morphine. So it goes from a mild to moderate pain potency analgesic to a strong analgesic. And so about 10% of it gets metabolized. And so when you have pain relief from codeine, we think it's from the 10% of the morphine that it gets metabolized into. Now, 2D6 is one of those finicky CYP450 enzymes that sometimes in different populations are ultra rapid metabolizers. So some people have this isoform of CYP2D6 that causes you to metabolize. Just the enzyme works in ultra drive. And so if that happens, you have more than 10% of that metabolized into morphine. So what would happen years ago is they would give children codeine for whatever reason. Those kids would be ultra rapid metabolizers, and then they would overdose and die. So we don't like to give children codeine anymore because of this, because they could be 2D6 ultra rapid metabolizers and get a ton of morphine from their codeine metabolized into it. Big concept to know. Ties in pharmacokinetics, ties in, they love to talk about pharmacogenomics and genetics, and it also ties in your knowledge of opioid pharmacology. So big, no 2D6 is, no, it's polymorphisms, ultra rapid metabolizer, and kids overdose on it. Oxycodone, another one that's mild to moderate in potency. It's often found in combination with ASA as aspirin and APAP as Tylenol, as Percodan and Percocet. It has many abuse deterrent measures. So, for example, Oxycontin, which is just a brand name of the long-acting form of just oxycodone, is coated with a crushable or an uncrushable coating. So pretty much they made this, they designed the drug and they designed the dosage form so that it can withstand, the tablet can withstand the human strength of a hammer smashing it. So they designed it so that it could withstand the force of you or I taking a hammer and smashing the tablet as hard as we could. Now, if you drive over it with your car, you're driving over it with your car, that's a lot of force. But, we do our best to try to keep people from crushing it up and then, using it to snort or inject or whatever they want to do with it. So there are abuse deterrent measures that are taken with some of these medications. And, the name Percocet actually comes from the fact that when they were initially looking at the drug, they found that for whatever reason, this oxycodone sort of made you the happiest. It perked you up. So that's why a lot of drugs of choice, patients the drug of choice is oxycodone because it didn't just get them high, it made them feel better. Hydrocodone, another mild to moderate with some antitussive effect. It's often found with ibuprofen or Tylenol, which is again APAP, as Vicoprofen or Vicodin. Again, as I've talked about with these last 3 drugs, the first summary slide applies to all. We come now to tramadol. Tramadol is another one of those funky ones with mixed receptor abilities. It's also a serotonin antagonist and a weak SNRI. As I made the point earlier, it's thought to be a weak mu agonist and therefore a safer opioid. Wrong. It is not. It is just as abuse potential as all of the other opioids. Do not go forward thinking that, I'm going to give somebody tramadol because I don't want to give them Vicodin. It doesn't work that way. Side effects, seizures, very important to remember. And then also, because it is an antagonist of the serotonin receptor, we do want to worry about serotonin syndrome and some of those, some of the possible interactions with SSRIs, MAOIs, increasing serotonin and getting serotonin syndrome. And so there's a little bit of a story behind these as well. So we found that the mu agonist was the way to induce pain control. But there are other opioid receptors. There are opioid kappa receptors, and then I think there's lambda receptors. No, it's not lambda, it's gamma. And so when we figured this out, we decided, okay, well, can we get pain control with some of these other receptors and spare respiratory depression? And that was the idea. We want to get some sort of a mixed agonist, antagonist, and all these different receptors and try to spare respiratory depression, because that was one of the main side effects of opioids and what we worry about. Unfortunately, we're unable to do that. Pain control comes from the mu opioid receptor, but respiratory depression comes from the mu opioid receptor. So we cannot separate pain control and respiratory depression. They're tied together. We cannot separate those two effects. But in the end, we are going to look at these 2 drugs here. So the first one is buprenorphine, which you may know as Suboxone. So for this exam, I want you to know that it is a partial agonist at the mu opioid receptor, and it also is a kappa antagonist. But it's used only for addiction. Patients are given this. It can help them with their cravings. It has an abuse deterrent in the naloxone that is built in to itself. So the way it works, so you have buprenorphine and you have naloxone. If you use it as you should, it is a medication that's administered sublingually. When it's administered sublingually, it goes straight to the liver. When it goes straight to the liver, the naloxone component, which is very highly metabolized by the liver, gets destroyed and the buprenorphine works. When the medication, if it's abused, which is, insufflated, which is through the nose, snorting, or used IV, the naloxone component is not broken down, so it actually inhibits the buprenorphine. So in this way, we're able to give a drug that is, sort of has a true abuse deterrent. However, now for this exam, he may give you a question where a patient has some sort of a contraindication to opioid therapy. There may be a patient who has abuse in the past, or is afraid of abuse, or has addiction, or has very bad asthma, has some reason you wouldn't want to give them an opioid, but they're in pain. And if anything like that happens, only for this exam, buprenorphine may be the answer. The last thing is it may precipitate withdrawal symptoms. So if you're going to start an addict on buprenorphine, before they start, you actually have to be suffering from withdrawal symptoms. Because if you're not suffering from withdrawal symptoms, you will be put into withdrawal symptoms of opioids because take this drug is a partial agonist. So as we talked about before, the partial agonist has better binding affinity than an agonist alone, and also an antagonist. We just don't have that here. So it will actually knock off any agonists that are still on the receptors and then act as an antagonist. So it can precipitate withdrawal. Sorry, it will. Finally, we have pentazocin. This is sort of, whereas buprenorphine was one of the good things that came out of our experimentation with agonists of different receptors, the rest of them really aren't used, and pentazocin is one of those leftovers. So this one is another partial mu agonist, but it's also a kappa agonist. So believe it can be used for moderate pain. It is combined with naloxone to form Talwin, which is another sort of Suboxone. But, it really isn't used. I've never seen it before. Side effects, one of the issues that they found with some of the other opioid receptors, like the kappa and the gamma receptor, are they kind of have some funky psychiatric effects. And because of that, they weren't used or aren't used very much. So for example, euphoria, the opposite of euphoria is dysphoria, and some of these medications would cause dysphoria. And if we're all going for euphoria in our lives, I don't even want to know what dysphoria is. So, I've talked about a couple partial agonists. Can you name some that we've talked about in the past? So, buprenorphine, varicycline, which was Chantix, our nicotinic partial agonist, and then aripiprazole, which was our third generation atypical antipsychotic. All right. Now, mu receptor antagonists. I've sort of already talked about these a little bit. We have naloxone or Narcan. It's our opioid reversal agent for an opioid dependence agent, very fast onset, and it's got a short duration of action. Its effect will not last. So somebody who comes in the emergency room after getting Narcan, within an hour or two, they could, the drug could wear off and they're back where they were, respiratory depressed and sedated. So, it doesn't work forever. High first pass effect, already talked about this and its ramifications because it's used in Suboxone, and then so it goes through the liver and it's highly metabolized, and then it can also induce withdrawal. So when you give a patient this, they're not very happy if they've just been using heroin. Naltrexone, so it can be used for the maintenance of abstinence. And then, as I said before, it can be used for alcohol dependence as well. That's another one that they do like to test, that it's a medication that can be used for alcohol dependence. We don't know why. The mu receptor must have some sort of implication. Longer duration of action, so it's not really used for overdose. It's actually an intramuscular shot that's been given once monthly.